Welcome to a new episode of Neomed AI Podcast, the podcast that offers insightful AI for better neonatal care. I'm your host, and today we're diving into a topic that's central to neonatal practice, Bronchopulmonary Dysplasia, or BPD. We'll take you from the basics, through clinical management, and right up to complex consultant-level decisions. We've got a compelling case thread to anchor us, and joining me is our expert. Thanks for being here.
Yeah, it's a pleasure. BPD remains one of the most frequent chronic respiratory problems in survivors of extreme prematurity, so it's a topic we see and feel every day in the NICU.
Exactly. So, to set the scene, imagine a tiny preterm infant. He's born at 26 weeks, weighs just 800 grams, and he received antenatal steroids. Initially, he's stabilized on CPAP, but soon his oxygen needs climb, and he's struggling to breathe. That will be our starting point. But before we jump back into his story, let's unpack some fundamentals. What actually is BPD?
At its core, BPD is a syndrome of lung injury and disrupted development. The lungs are still forming when these babies are born, so the combination of oxygen, mechanical ventilation, and inflammation can halt normal alveolar growth. What you see pathologically is fewer and larger alveoli, some areas of emphysema and fibrosis, and injury to the developing blood vessels.
So it's not just one uniform disease, but a mosaic of injuries.
Exactly. And those injuries come from multiple directions. Antenatal factors like chorioamnionitis, maternal smoking, or poor nutrition prime the lungs. Postnatally, oxygen and mechanical ventilation are necessary but double-edged swords. Infection and sepsis further fan the flames of inflammation.
That's a lot for a premature lung to handle. How do we actually define BPD these days? I know the definitions have changed over time.
They have. The older 2001 definition required at least 28 days of oxygen, and severity was judged at 36 weeks postmenstrual age by how much support the baby needed. The more recent NICHD revision drops the 28-day rule and uses the type of support at 36 weeks, nasal cannula, non-invasive or invasive ventilation, plus a chest X-ray to confirm lung disease.
That seems more practical. Which babies are most at risk?
The risk is inversely proportional to gestational age. Infants born less than 30 weeks gestation have immature lungs and limited reserve. Additional risk factors include antenatal inflammation, maternal smoking, prolonged ventilation, high oxygen exposure, sepsis, and suboptimal postnatal nutrition.
You mentioned inflammation as a central player. Could you expand on that?
Sure. In animal studies, either oxygen or mechanical ventilation alone can trigger inflammatory cascades leading to poor alveolar development. Blocking these mediators can improve outcomes, highlighting the central role of inflammation. Clinically, infections like sepsis or necrotizing enterocolitis amplify this response, worsening lung injury.
That explains why infection prevention is so important. Let's return to our case. Our 26-weeker is on CPAP, but struggling. Why do we push for non-invasive support early on?
Because intubation itself causes trauma. Starting with CPAP helps maintain functional residual capacity without the barotrauma of ventilation. When surfactant is needed, we prefer the LISA technique, passing a fine catheter through the vocal cords under laryngoscopy while the baby continues breathing on CPAP. This avoids full mechanical ventilation and has been shown to reduce air leaks and BPD.
And timing matters? At what point do you intervene with surfactant?
Yes, early but not prophylactic. For a baby on CPAP, if the FiO2 creeps above 0.30 despite a PEEP of at least 6 centimeters H2O, that's our cue. LISA gets the surfactant in without sedatives. Sedation increases the risk of apnea, so we typically use sucrose and keep a team ready for immediate rescue if needed.
Once we've settled on CPAP and surfactant, where do we set our oxygen saturation targets?
UK practice follows the NICE quality standard and the NeoProm meta-analysis. We aim for saturations between 91 and 95%. Lower targets are associated with increased mortality and higher targets risk retinopathy. Evidence for more mature preterms is thinner, so local policies may differ, but 91 to 95% is generally adopted.
Let's talk fluids and nutrition. These babies often teeter on the edge of fluid overload. How do you manage that?
Carefully. We start IV fluids around 70 to 80 milliliters per kilogram a day and adjust based on weights and electrolytes. Sodium supplementation is delayed until after day 3 or if the baby loses more than 5% of birth weight. We commence parenteral nutrition immediately, building up protein and lipids. Minimal enteral feeds with express breast milk begin very early to prime the gut.
And then there's caffeine. Why is caffeine therapy such a big deal in preterm respiratory care?
It's our favorite respiratory stimulant. Caffeine improves diaphragmatic contractility and breathing effort. The Caffeine for Apnea of Prematurity trial showed that starting caffeine early, around the 3rd day, reduced both apnea and rates of BPD. We use a loading dose of 20 milligrams per kilogram, followed by 5 to 10 milligrams per kilogram daily.
And finally on the basics, how do antenatal steroids factor in?
A single course of antenatal corticosteroids reduces the incidence of respiratory distress, necrotizing enterocolitis, and intraventricular hemorrhage. Is recommended for mothers at risk of preterm birth before 34 weeks. One repeat course can be given if delivery doesn't occur and the risk persists, but repeated courses carry risks of impaired fetal growth.
That rounds off our first level. For our listeners, the key messages are: prevent injury by supporting spontaneously breathing infants, give surfactant early when FiO2 exceeds 0.30, keep saturations between 91 and 95%, start caffeine and restrict fluids carefully. Shall we advance our case?
Let's do it.
It's 6 hours later. Our infant is on CPAP at 6 centimeters H2O with an FiO2 of 0.35. He's working harder and his blood gas shows mild acidosis with a PaCO2 of 6.5 kPa. Should we step in with surfactant?
Yes, his oxygen requirement has crossed out 0.30 threshold at adequate PEEP, so he fits criteria for rescue surfactant via LISA. Early intervention at this stage reduces later ventilation needs and improves survival without BPD.
When preparing for LISA, we often get asked about analgesia. What's your approach?
LISA is uncomfortable, but sedatives come at a cost. Studies show no clear advantage in procedure success when using opiates or midazolam versus sucrose. Sedation prolongs apnea and may necessitate full ventilation, so we perform LISA without systemic sedation, but with adequate analgesia and a team ready to manage the airway if needed.
Suppose the baby fails CPAP and requires intubation. How would you ventilate?
We'd use volume-targeted ventilation. This mode sets a target tidal volume, usually 4 to 6 milliliters per kilogram, and the ventilator adjusts pressure accordingly. It reduces fluctuations, minimizes volume trauma, and has been shown to shorten ventilation duration, decrease pneumothorax, and reduce the combined outcome of death or BPD compared with pressure-limited modes. PEEP should be titrated to keep the lungs open while minimizing FiO2. And we're increasingly comfortable allowing modest capnia, PCO2 between 5 and 7 kPa, with a pH over 7.22.
Right, and what about inhaled nitric oxide, INO, for pulmonary hypertension?
Routine INO use in preterm infants has not improved survival or BPD outcomes. It should be reserved for documented pulmonary hypertension unresponsive to optimizing oxygenation and ventilation. Even then, the evidence is limited, so it's a short trial rather than long-term therapy.
Now, those tricky situations where the baby just won't come off the ventilator, which systemic steroids do we reach for?
Low-dose dexamethasone using the DART regimen, that's a small dose over 10 days, improves extubation rates with fewer neurodevelopmental concerns compared to higher doses. Prophylactic hydrocortisone started within the first 2 weeks may improve survival without BPD, but it increases the risk of spontaneous intestinal perforation, particularly in infants receiving indomethacin. We avoid inhaled budesonide outside trials because it reduced BPD incidence in one study but might have been associated with increased mortality.
Vitamin A injections used to be popular. Do they still have a role?
Intramuscular vitamin A does raise plasma retinol, and early trials suggested a modest reduction in BPD, with a number needed to treat around 14. Later studies found only a small benefit, and the injections are painful. Centers with low BPD rates generally don't use vitamin A routinely. Oral vitamin A hasn't shown clear benefit either.
And bronchodilators. Parents sometimes ask about salbutamol inhalers.
Beta agonists reduce airway resistance and can improve compliance transiently. However, the evidence base is small and the benefits are short-lived. A trial of a bronchodilator is reasonable in infants with wheeze or hyperinflation, but we continue therapy only if there's a clear clinical improvement.
Diuretics are another tool we use frequently. What does the evidence say?
Short-term courses of thiazide with spironolactone or intermittent furosemide can improve compliance and treat pulmonary edema, but the effect disappears when the drug is stopped. There's no evidence that long-term diuretics reduce oxygen dependency or shorten hospital stay, and they carry risks of electrolyte disturbances and nephrocalcinosis. So they're reserved for acute fluid overload, not for routine chronic use.
Let's not forget pulmonary hypertension. How do we approach that?
We start with echocardiography to confirm the diagnosis. Management focuses on optimizing ventilation, treating hypoxia and acidosis, and ensuring adequate growth. Supplemental oxygen is used to maintain saturations above 93%. Sildenafil may be considered off-label for moderate pulmonary hypertension, but there's limited data. Severe cases should be referred early to specialist pulmonary hypertension centers.
There comes a point where some infants still need ongoing ventilation. Is tracheostomy a consideration?
It can be, but it's rare in the UK. We consider tracheostomy for infants who cannot wean from ventilation despite optimal management, or who have significant airway malacia. Decision-making is multidisciplinary and requires parental counseling. Long-term outcomes vary and data are limited.
And what about lung transplantation? Does that ever happen in this population?
Lung transplant is reserved for life-limiting progressive disease and is exceedingly rare in BPD. It's only after all other therapies have failed, and there's very little data on its outcomes in infants.
Thanks for walking us through those management nuances. Let's shift into some controversies and extras. I'll throw out a topic and you tell us what we know, what we don't, and where the debate lies.
Fire away.
Permissive hypercapnia. How high is safe?
Generally, allowing a PCO2 of 5 to 7 kPa with a pH above 7.22 is considered safe. Hypocapnia increases the risk of brain injury, and severe hypercapnia can worsen BPD and retinopathy, so a modest rise is part of lung protective strategies.
NAVA versus volume guarantee ventilation.
Neurally adjusted ventilatory assist uses the baby's own diaphragmatic EMG to trigger breaths, improving synchrony and potentially reducing the need for sedation. But trials haven't demonstrated better long-term outcomes compared with conventional synchronized modes. Cost and availability also limit widespread use.
Combination therapies like giving caffeine before LISA.
There's interest in whether giving caffeine before the LISA procedure might further reduce BPD, and some early results are promising. But higher doses raise concerns about seizures or cerebellar anorexia. More research is needed.
Inhaled steroids.
Budesonide mixed with surfactant reduced BPD in one trial but was associated with increased mortality. Because of that, most guidelines advise against routine inhaled steroids outside clinical studies.
Vitamin A dosing?
Oral vitamin A hasn't shown benefit, and intramuscular vitamin A has only a small effect. Ongoing trials are exploring higher dose oral regimes, but as of now, it's not routine.
Post-discharge diuretics.
Data from the US suggests that many infants go home on diuretics only to have them stopped at the first follow-up. Unless there's ongoing pulmonary edema, continuing diuretics at home isn't supported by evidence.
Sleep studies?
Sleep-disordered breathing is common in children with a history of BPD. In one cohort, the average respiratory disturbance index was around 10 events per hour, and secondhand smoke exposure worsened oxygen desaturation by a couple of points. Polysomnography helps tailor home oxygen and ventilation settings.
Home oxygen weaning and Epicure data.
The NHS GGC guideline recommends discontinuing home oxygen once overnight oximetry shows a mean saturation of at least 93%, with less than 5% of the nights spent below 90%. Families should know that in the Epicure cohort, the median duration of home oxygen was about 2.5 months beyond the expected date of delivery.
And long-term outcomes?
Long-term outcomes vary. Many survivors have reduced diffusion capacity and exercise tolerance into adolescence, and they're at higher risk of pulmonary hypertension and respiratory infections. Neurodevelopmental impairments and learning difficulties are also more common, so multidisciplinary follow-up is essential.
Before we move to our complex case, can you contrast how management differs between the UK and other regions like North America?
Sure. In the UK and Europe, we typically favour volume-targeted ventilation with permissive hypercapnia and early extubation. Steroid use is cautious and low dose. Tracheostomies and home ventilation are uncommon. In North America, some centres still use pressure-controlled modes or high-frequency oscillation more liberally. There's wider variation in steroid regimes and a greater readiness to adopt home ventilation and tracheostomy. Differences reflect not only clinical interpretation of the evidence, but also healthcare infrastructure.
Time to challenge ourselves. Imagine our original 26-weeker is now at 36 weeks PMA. He's been on and off ventilation but can't stay extubated. He's on fairly high settings and has signs of pulmonary hypertension on echocardiography. How would you optimize his ventilation now?
At this stage, the lungs are stiff in places and hyperinflated in others. We often switch to what's sometimes called chronic lung disease ventilation. Larger tidal volumes around 8 to 12 mils per kilogram, longer inspiratory times of 0.7 to 1.2 seconds, and lower respiratory rates. This allows gas exchange across less compliant lung units. We match PEEP to the baby's intrinsic PEEP and adjust inspiratory flow to promote synchrony. Continuous monitoring of blood gases and lung mechanics is key.
This baby's family asks about taking him home on a ventilator. When do we consider home ventilation?
Once the infant is medically stable but still requires chronic ventilation and caregivers are trained. Typically, we consider it when they're over 5 kilograms, can tolerate feeding, and have a stable respiratory status. Home ventilation rates are low in the UK, so each case is considered carefully.
And for his pulmonary hypertension?
We'd maintain saturations above 93%, optimize ventilation and diuretics, ensure he's thriving nutritionally, and use echocardiography to guide therapy. Sildenafil could be introduced after cardiology consultation.
Would you give him systemic steroids now?
If he's failed multiple extubations despite optimized management, a low-dose dexamethasone course can tip the balance. But we'd counsel parents about risks like gastrointestinal perforation and possible neurodevelopmental effects. Hydrocortisone started later tends to be less effective.
Tracheostomy, yes or no?
It's an option for infants requiring prolonged ventilation who can't be extubated and who may benefit from more stable airway access. Multidisciplinary discussions with surgeons, respiratory therapists, and family are crucial. We don't have robust data on long-term outcomes, so it remains an individualized decision.
There's a lot of buzz about experimental therapies like stem cells. Should we offer them?
Mesenchymal stem cell therapies are being studied and look promising in animal models, but human data are limited. These interventions should only occur within clinical trials. We can't recommend them routinely.
When counseling this family, how would you frame the prognosis?
I'd be honest that severe BPD can mean prolonged respiratory support, frequent rehospitalizations, and possible growth and developmental delays, but many babies do improve over time. Our job is to support his lung growth, optimize nutrition, and monitor for complications. Ongoing follow-up with the wider team, including physiotherapists, dietitians, and developmental specialists, is vital.
Let's wrap up with some rapid-fire thought experiments. For our listeners, pause for a moment and think how you'd answer before hearing the expert. 1. You're caring for a 28-week infant on CPAP. FiO2 is 0.28 and the baby's comfortable. Do you give surfactant?
Not yet. FiO2 is below 0.3, so we continue CPAP and watch closely.
A 25-week baby on day 2 is on 100 mils per kilogram per day of fluids due to oliguria. Is that appropriate?
No, we aim for 70 to 80 mils per kilogram early on. Excess fluids raise the risk of PDA and BPD.
A 33-weeker who is now 3 weeks of age and can't be extubated despite 2 attempts. Parents worry about steroids. Would you start them?
I'd discuss a low-dose dexamethasone course, explain potential benefits and side effects, and involved parents in the decision.
A 30-week baby at 38 weeks PMA is on 0.1 liters per minute oxygen. Overnight oximetry shows mean saturation 94%, with only 2% of the night below 90%. Can you stop oxygen and plan discharge?
Yes, if mean overnight saturation is above 93%, with less than 5% of time below 90% and no desaturation episodes, we can discontinue oxygen, repeat oximetry in room air, educate parents, and arrange a follow-up.
Before we close, let's run through a practical checklist. Could you recap the key elements of preventing and managing BPD?
Sure. In the delivery room, delay cord clamping for at least 60 seconds, start CPAP immediately, avoid routine intubation, and give caffeine early. If FiO2 creeps above 0.30 on CPAP at 6 centimeters H2O, give surfactant via LISA and avoid sedation. Choose volume-targeted ventilation, adjust PEEP carefully, and allow a bit of hypercapnia. Avoid hypocapnia. Start fluids at 70 to 80 milliliters per kilogram per day, delay sodium supplementation, and begin nutrition early. Pharmacological strategy: early caffeine, low-dose hydrocortisone or dexamethasone after careful consideration, no routine diuretics or inhaled budesonide. Target oxygen saturations of 91 to 95%, monitor blood gases, and avoid routine sedation. Plan for early extubation, assess for pulmonary hypertension, and only consider home oxygen once overnight saturations are stable.
And on follow-up?
Many former BPD patients have reduced lung capacity, so they need periodic pulmonary function tests. Ensure catch-up growth, screen for sleep-disordered breathing, monitor for pulmonary hypertension, and support neurodevelopment. Importantly, avoid rapid oxygen weaning. Don't send them home with apnea monitors unless indicated. Ensure they receive RSV prophylaxis and counsel families about smoke-free environments and travel with oxygen.
Brilliant. Let's end with a few succinct take-home messages for our listeners. 1. Early non-invasive support and timely surfactant delivery via LISA are cornerstones of preventing BPD. 2. Management is about balancing lung protection with adequate ventilation, use volume-targeted modes, accept moderate hypercapnia, and avoid unnecessary sedation or diuretics. 3. BPD doesn't end at discharge. Structured follow-up, careful weaning from oxygen, and multidisciplinary support are essential for long-term outcomes.
Absolutely. And I'd encourage clinicians to remain vigilant for pulmonary hypertension and sleep-disordered breathing, and to involve families as partners in care.
To leave you with a thought, given the rapid advances in neonatal care, where do you think the next major breakthrough in preventing or treating BPD will come from? Stem cell therapies, precision ventilation, better biomarkers? It's exciting to ponder. That's all for today's episode of the Neomed AI Podcast. Thanks to our expert for sharing such valuable insights. And thank you, listeners, for joining us on this journey from delivery room to long-term follow-up. Just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.